Hello, everybody in the auditorium and on Zoom. Welcome to the first Engel rounds of the year for 23-24. And our speaker today is Dr. Marsha Wittink. And the title of today's presentation is Integrated Care, Patient Priorities, and Outcomes That Matter. I'll give her a better introduction than that in a minute, but before I do, I want to just mention a few things, especially for the people on Zoom. One is all the cameras are off and microphones are off. However, we'd like to hear from you in the form of questions or comments, but don't use the chat box. That's really reserved for the panel and interpreters, et cetera, who are here. So put any questions or comments in the Q&A box at the bottom of your screen, and we'll get through as many of those questions as we can at the end. Also, again, very important to remind people to fill out the evaluation at the end. A QR code will come up. There'll be a link also, and then tomorrow an email will come out with the link again. So please fill it out when you can. Okay, so today, at our first Engel Rounds presentation this year, Dr. Wittink is going to speak about her work. Dr. Wittink is she's an associate professor, I should say, first of psychiatry, with a joint appointment in the Department of Family Medicine. And she's the academic chief of the new Medicine and Psychiatry Division. She's also the medical director for the Inpatient Medicine and Psychiatry Unit. That's often called the MIPS unit. And she's the chair of the National Medical Psychiatry Unit Consortium. And the significance of that really is that this idea that there should be integrated medical and psychiatric care, and that this is a field that can evolve and that should be standards that people should stick to. This is a really growing area that Marsha is one of the leaders in the United States in. Her research has focused primarily on integrating medical and mental health services, especially as it relates to aging, and particularly for older adults who have multiple medical and psychiatric issues. She also has a strong interest in assessing patient priorities. And that's really a unique focus in what can easily be just a field that focuses solely on disease and blood markers of illness. So patient priorities, what do patients want for their lives? What do they want for their treatment? And then how is that assessed? And then when you assess it, does it actually affect the care that patients get? Does it affect the outcomes that patients get? These are important questions, and there's really very little known about that, and really very few people working in that area. So today we're going to hear some about some of Dr. Wittink's work in that important area. So let's give her a nice welcome for one of our own. Okay.
Thank you, Steve. Can anybody hear me? Can you hear me? Yes, good. All right. So I hope you'll indulge me a little bit today. There's a lot of slides in here, and I might flip through some of them because it's probably more content than anybody wants to hear about me. But it's hard when you start at this stage in your life, a certain stage we sometimes call mid-career, midlife. Happens to be where I'm at. My kids just left the home, and I'm taking stock. So you're going to get a little bit of that. Sorry about that in advance. But I hope you'll find the journey somewhat fun. So we're just going to go through these real quick. All right. So I don't have any disclosures, but I do have a lot of acknowledgments, and there are probably a lot of people in the room here who are on this slide, and there are people who did not fit on this slide. But just a lot of people have really had a big impact on my career here at the University of Rochester and before that as well. And I really want to make sure that I have a huge shout out to my medical team, primarily on the inpatient side, but also on the outpatient side of MIPS as I get to know more and more of them. They really help drive my passion for continuing this work at times when it's hard and nobody seems to understand what the heck it is we're trying to do, whether it's clinically or trying to show outcomes or get funding, which I'll talk a little bit about today. So I hope that This is another title that I thought of. How the heck did a family doc end up in psychiatry, and my circuitous path to both delivering and studying integrated care. And I'll talk a little bit how I go back and forth between my clinical work and how that informs my research, and how my research got me here in the first place. So again, the theme here is that things are circuitous, whether you're a clinician or a researcher. And for those of you who are sort of early in your career, I hope that you see that this is normal. There are a lot of people who have this path. There are some people who go straight forward, but it's a fun path, so hopefully you'll follow along with me. So the goals of the talk, like I said, I'm going to talk a lot about who I am, how I got here. We're going to talk about med psych units, which you'll see as abbreviated as MPUs, so you know what that is, med psych unit. Another term that's often used to describe med psych units is CIU, which stands for Complexity Integration Unit. Basically a term that was used to reduce the stigma of creating these units for people who don't like the word psychiatry or mental health. Complexity Intervention Unit. So I don't use it because I don't think it actually describes what we do. And then we'll talk a little bit about some data and building capacity for research, which Steve knows a lot about, and then sort of my next steps, which I think are sort of coming full circle a little bit. So what drives my scholarship? Again, like, how did I get here? Why am I here? The things that really drive scholarship for me are my clinical experiences. Fundamentally, I'm a physician, and as a physician, I spend a lot of time listening to my patients, and that's one of the things that I love about being in psychiatry. You all share that as well, the importance of really listening and kind of gathering information. The other thing that really drives my scholarship, quite frankly, is frustration. When things are broken, and maybe that's why I'm a doctor, I like to fix, but that's what I want to try. Those are the challenges I really want to delve into, maybe sometimes full-heartedly, because they really are challenging, but that's really what drives it. I want to try to fix the things that patients are telling me, that I'm feeling, that my team is feeling, and most of that comes back again and again to the fragmentation of our healthcare system. And I really have this desire to change the way we deliver care. We all know since the pandemic, things have really come to the fore, but they were obvious before that. They've just come out in the news a little bit more. People are paying more attention to how fragmented and how broken our system is. And so that's really what I'm most passionate about. How can we find little blips of like hope and new ways of doing things that will really make an impact on patients' lives and address their needs? All right, so this is the path. So we're going to see this slide a couple times. Here's my circuitous path, and this one's actually, it looks kind of nice, but yeah, there's a lot of curves and turns, and those mountains in the background, they always seem closer than they really are. So you just keep on going and keep on taking these turns. So a little bit about me, where I started. In between high school and college, I spent first a year in India, which I think still had a big impact on who I am, and just sort of looking at systems from the outside. It really gave me this outsider perspective to be in a different culture, to be really immersed in it. And then when I decided to go to college, or I knew I was going to college, but when I decided what I wanted to study, I was interested in the human, the mind, and how we think, and increasingly in biopsychology and sort of the overlap between sort of the physiology of the brain and how that's manifested in behavior. So was really thinking I was going to be a lab researcher, worked with rats. In my last year of college, was like, okay, I'm going to apply to PhD programs, did that. And then I was working in a lab, and everybody else working in the lab was going to medical school. And I thought, maybe I don't want to work with rats. And what I was really interested in, again, was the human mind. These were just models for the human mind. And so at the last minute, I decided to apply to medical school. And I ended up at a special medical school called Jefferson. I think it's now called the Sidney Kimmel School of Medicine, but it is in Philadelphia. And what's special about it is there's a really strong history of primary care and family medicine in particular. It's one of the founding places for the field of family medicine. And for those of you who aren't really familiar, family medicine is a specialty. It's not just a generalist. It's really based on this foundational idea that health systems and families are really important to health, and that we should be thinking about the holistic care of patients and their communities. And so there's a lot of emphasis on community building, community participatory research, on understanding the impact of psychology and sociology and anthropology on health. So it really fit well with my kind of overall understanding on what I wanted to do with health. So was a good fit. And all along my time in family medicine, I kept thinking about older adults and the complexity of multimorbidity and the mental anguish that a lot of folks were facing when they would come into their primary care office. Depression was a very big part of what we saw on the front lines, but it was never teased apart. You know, by the time depression gets to psychiatry, the patient has to some degree bought into it, right? They're there because somebody diagnosed it, somebody said that you probably need help, they've themselves accepted it, or maybe their spouse tried to get them to accept it, right? But when they're in primary care, they're not necessarily thinking about mental health over here and physical health over here. They're just feeling all this distress, right? So that led me to be interested in doing a fellowship in academic medicine and getting a master's degree. Across the way in Philadelphia at the University of Pennsylvania, there were two researchers there who were just starting up this program called the Spectrum of Depression in Older Adults. And it was just such a cool study. Steve and I were talking about just doing things that are cool. And that was like, I wanted to do this really cool thing. I wanted to be a part of it. And it gave me an opportunity to learn what's called mixed methods. So to look at quantitative methods as well as qualitative methods and how they can inform each other. So there's only so much we can learn from data that is a survey. We can see, you know, what the correlations are, but we don't know why. So qualitative data allows you to go more in depth by asking people, what do you think, what's going on here? Can you explain this correlation? And you go back and forth. And so I got some training in medical anthropology as well as in epidemiology. And that led me to really start to explore this notion of what do patients think and what do physicians think about depression in primary care. And I undertook a lot of studies, a lot of qualitative studies, focus group related, semi-structured interviews, all based on this large study that I was a part of, this epidemiological study, looking at primarily older adults, and learned a lot of things about communication. So these are just some of the titles, just to give you an idea. Patients kind of think about things medically, but they also think about what they're feeling, right? They may have certain ways of talking to doctors that doctors don't always pick up on, that it's actually depression that they want help with. And that there are cultural differences, right? That ethnicity and perceptions of how you deal with things can impact what you ask for in the doctor's office. Fundamentally, there were these two things that I was kind of holding in my mind, that patients want their mental health and their physical health together, right? It makes sense, like it's not separated in their brain. They just want one-stop shopping, quite frankly. Like, come on, do I have to go somewhere else? And they also want their primary care doctor to just kind of know what's going on with them. So they appreciate that relationship, that longitudinal relationship is really, like, takes time to build that trust. And so they're hoping that their doctor will kind of pick up on what's going on. They don't just want referrals to psychiatry or to a therapist. So of course we know about collaborative care and the benefits of that and having the warm handoff, all that's really important to patients. And that makes sense why those things work so well. And then there's this piece of this explanatory model, which is the reason I feel what I feel. A lot of people have a story, a narrative they tell. And if that narrative doesn't fit with you're gonna have this thing that affects your epinephrine and your norepinephrine and your serotonin, like, it just doesn't compute, and they're very unlikely to adhere. And PCPs, primary care providers, get that too. They see that patients are having trouble engaging in treatment, and they're having trouble adhering to treatment because of that disconnect, right? So what they really want is help with all these demands, all these competing demands. They have to deal with a lot in primary care, and this is only compounded lately. This is really, you know, the amount of documentation that primary care doctors have to do, I don't need to tell you, it's overwhelming. And they really wanted the ability to understand what are the communicated things that patients have going on in their lives? What's the context of their world? What are the challenges going on at home? Because that would help me then tailor what I want to talk to them about and how I'm going to help them. Bottom line is it's very tough to do this when you've got 15 minutes, right? So how do we make this better? So I was sort of conceptualizing this at the time, thinking about anthropology, thinking about epidemiology, working with some really smart people, Joseph Gallo and Francis Barg at Penn. And it really occurred to me that what I was interested in was the decision-making around treatment and you know, what you're gonna do to manage illness and depression in particular. And there's sort of this challenge that exists in shared decision-making. There's a imbalance, right? One person has the knowledge of what's available and what we can do about it and what we know about the disease. And the other person really holds a lot of knowledge of themselves, but I put implicit in there because they're not always necessarily able to articulate it, right? You guys know this from psychiatry, psychologists, right? There's a knowledge that we have, but how do we help patients articulate that? And so I really got interested in this idea. Could we understand what patients' preferences are and then help tailor the treatment to their preferences so that we could get them to engage better? Turns out there's this cool part of University of Pennsylvania called Wharton, which is well known for its business school, but they also do a lot of work in what they call customer or consumer analytics. And it turns out that companies know a lot about how you make decisions, right? This is what social media is. And so I was like, could we tap into this? This was before social media was as I guess, detailed as it is now, but there was a lot that they were doing already to try to understand how people make decisions about what product they want to buy and how to develop new products that would be meeting the exact needs of what patients want. And one tool is something called conjoint analysis, which is something that basically just sees how patients value different features or attributes of a product. For example, if you make a decision between Pepsi and Coke, do you make the decision because of the brand, or is it because of the sweetness, or because of the bubbles, or because of the color? So you can find out which pieces are actually driving a choice. And I thought this would be really cool to think about with patients. And so this led to my initial line of scholarship. I had a career development award from the National Institute of Mental Health, focused on tailoring treatment for depression to older adults. And I was building on these mixed methods that I was learning and this conjoint analysis. And that eventually led to an R34, which is a sort of building grant pilot work that kind of moved from that really, I started really getting interested in this idea of personalized medicine and tailoring treatment to patient needs. This is just an example of the kinds of things that I was doing a ton of at the time. I was doing a lot of recruiting patients to studies and asking them to go through a series of comparative choices that continually sort of manipulate the options based on the attributes of a product or treatment, in this case, depression treatment. So you can have the brand of counseling and medication, or you can take that brand away and you can talk about side effects or where it's delivered, or what you have to work on, or perhaps even your explanatory model. And so we did a little series of these things and learned a lot about how people make decisions and what kind of influences things. Turns out that the brand of counseling versus medication overrides everything. So you have to kind of remove that if you want to take that. The other thing that drives things is cost, as you might imagine. And that led me to this sort of next phase of saying, okay, there's all this interest right now in personalizing treatment, especially in mental health. Can we use epigenetics? Can we understand physiology and really tailor things to patients' chemistry? And I was like, but what about tailoring it to their values? Could we use values markers, just like we use genetic markers, to identify types or subtypes of people in the population to create new treatments? And I kind of went down deep. Little cavern into this world, and it was really interesting and very I guess philosophical and cool, and I liked it. But this other thing happened at the same time, which was as I was working with the participants, they kept saying, you know what, this tool is really cool because I'm learning something about myself when I do it. You know what I really wish? I could show it to my doctor. And I was like, oh, yeah, that's really pragmatic, and maybe that's better for who I am as a physician, and I should sort of look into that. So maybe we can actually use this tool to affect communication. And right about that time, I was giving a talk at a conference somewhere, and I met somebody from the University of Rochester who said, all this values marker stuff, I think you're going in the wrong direction, but the tool you got is really cool. And I was like, yeah, my patients told me the same thing. He said, why don't you come to University of Rochester, give a talk, just have fun. And that was Paul Duberstein who brought me here. And long story short, they said, we're building this new lab here. There's this Center for Communication Disparities Research. We're really interested in bringing more people who are interested in healthcare decision-making. Why don't you come here? And then, you'll bring your grant, so you'll be working on your research. And then just to keep your fingers busy with, doing a little bit of clinical work, since you're a physician, why don't you work on this little unit we got down the road, down the hallway, called Inpatient Medicine Psychiatry, our Unit 19200. And then I fell in love. And then, things evolved from there. But first, I continued to kind of think about this work that I'd been doing and what I had learned about from patients. And really what they were telling me was, I want to be able to communicate these things to my physician. I don't really like that there's all these silos. There's things that are important to me, which include what's going on in my life, my social world, as well as my mental world, that I want to communicate. And so over a series of a couple of years and with some grants, I developed this tool basically with some really interesting developers. And the idea was to be able to use an app in the waiting room in primary care offices to help patients address these issues of power asymmetry that we were talking about before, right? So the patient has some implicit knowledge of themselves, but they don't know how to communicate that. The physician doesn't know how to ask it. There's arbitrary boundaries that we have in medicine, like, we deal with hypertension, heart disease. Maybe I'll talk to you a little bit about whether you can afford your medications, but don't talk to me about, housing or food insecurity. That's a little bit over, that goes beyond what my knowledge is or what I can help you with. And then there's this piece of the priorities, right? So we thought with these tools, could we try to help patients kind of prompt them to have discussions by starting in the waiting room, getting them to think about things before they even went in to see their doctor. And so that was another R34 that I had from NIMH called Improving Communication and Multimorbidity. So we specifically recruited folks with 2 or 3 or more chronic medical conditions and depression or anxiety. So folks who are really dealing with a lot of complexity in their lives, to try to hone in what among all the things is really most important to them so the physician doesn't miss it. And one of the coolest papers that I've ever written was called The Doorknob Phenomenon. And basically what we found was that our tool helped patients bring up what was really important to them earlier in the office visit. So the doorknob phenomenon, anybody who's worked in a clinic knows that as you go to the door and you're like, bye, see you next, in a couple of weeks, they're like, oh, by the way, doc. And then the real thing comes out, and it's a big, opening up Pandora's box sometimes because you got 5 other patients waiting. So this idea was, can we actually prompt them to bring up what's important earlier? And this is kind of the sort of thing that it looked like. They would have a little printout at the end of doing this little iPad app in the waiting room before they went in, where they basically did a little trade-off kind of analyses and decided what was most important to them. And not only did we show them what they picked so that they could agree afterward and say, yeah, that is most important to me. And sometimes it was revealed to them. They're like, that was a surprise. That's not actually what I thought I was going to say, but after doing all of that, that's what kind of came out. And you're right, that is more important, and I don't bring it up. And then we also gave them really concrete tips for how to talk to their provider, because it's one thing to say this is important, but then what does the physician do about it? And this was our focus groups with physicians who really wanted to know, okay, if you're going to tell me this is important to a patient, how am I going to talk to them about that? So they got tips on how to talk to the provider, and then they also got resources. And what we found were that patients were 6 times more likely to disclose their stressors, whatever it was that was most important to the primary care provider. They brought it up earlier in the visit, and they reported higher confidence that the primary care physician actually understood what their needs were that day. And the really important finding, I think, too, is that this did not add anything to the visit. So it didn't create a longer visit. So this led to sort of the next phase of my research, where a lot of people got excited about the work I was doing, and I got to collaborate with some really fun folks. 2 people who I had a lot of fun with were Ellen Polishuk and Kate Cerulli. We had 2 consecutive PCORI grants, patient-centered outcomes research, a sort of funding grant institution that is really interested in patient outcomes and patient-centered issues. So my area, lending that to their research, was sort of well received. And we had a lot of interesting findings on how we could develop tools together with patients and community members to really address what their needs were in the context of things like postpartum depression and intimate partner violence. I also was a part of other research in cancer, and some of this work is still going on, where you can imagine there's a lot of, it makes a lot of sense to be thinking about tools that help patients communicate what's really important to them earlier on in the course of their disease, understanding better what all the risk factors are and the side effects. So there's been a lot of work related to this kind of assessment that I've been doing. At the same time, that meant I didn't have my own funding anymore. So I was on a lot of people's grants and really having fun collaborating, but that meant I had to spend a little more of my time doing clinical work. And I really started enjoying that. And my clinical mentor, Talva Oliveira, said, and the chair at the time, Eric Kane, said, hey, why don't you take on the role of the medical director? I think you could really do some great things there, and you seem to like it there, and it's true. Every time I was getting frustrated in my research, I'd go back to my clinical team and be like, oh, it's so great to just see patients and do this stuff. Even though it's a very complicated patient population we take care of, and there's a lot of challenges there too. So as I made the decision to go ahead and take on this medical director role and really try to understand all the inner workings of working with a team that's multidisciplinary and thinking more about a patient population that's inpatient as opposed to outpatient, so acute care. And again, the integration of medicine and psychiatry. These patients were not thinking about their physical and mental health separately necessarily. And the whole goal was to try to integrate everything and do it in one place. So lots of similarities to my research, my interests before, but in a different setting. Of course, it's the flip. It's bringing medical care into psychiatry as opposed to the other way around. What was really cool about working on 192, and it continues to be really cool, is that we have this very robust unit-based performance program, which is something that was just being rolled out when I kind of took over throughout the hospital. And each unit has quality improvement initiatives that happen all the time, but this was sort of a consolidated way of communicating across units and getting support from the hospital to push ideas forward. Things that are important to the health system that usually have to do with finances, like reducing lengths of stay, reducing readmission rates, but it turns out they're things that are important to clinicians and patients as well. And so I really had the opportunity to kind of use some of my research skills in that area. And that's just a picture from our website. So once again, thinking about what's driving my scholarship, listening to patients, and also thinking about that frustration. So all of a sudden my thinking shifted a little bit, because when I was dealing with the patient population 192, which had been set up really by Talva Oliveras and her predecessors to care for patients with severe mental illness, so those with schizophrenia, bipolar disorder, who are elsewhere in the hospital but are not getting the best medical care there. That's really what 192 was set up for. Now 192 does a lot more than that, but that was her initial passion. And she's very good at being contagious with her passion, if you've ever hung out with Talva. And I've become very passionate about this and spent a lot of time thinking about how this really is the largest health disparity that we don't talk about. Folks with severe mental illness die 20 to 30 years earlier than the rest of the population who don't have severe mental illness. And it's not because of psychiatric disease, as we all know in this room, but I have to say that over and over again. They're not dying by suicide at a higher rate. That is part of it, but it's much bigger due to cardiovascular disease and diabetes. So there's an enormous need to be delivering better medical care to these folks. And psychiatrists aren't doing that. They're doing some of the screening and they're thinking about it, but it needs to be somebody on the medical side who's delivering this. And so I really wanted to think more about what is the opportunity to kind of disseminate this really cool model that we have, this med psych unit that we have at the University of Rochester. And there was also some really interesting papers that came out that I highly recommend taking some time to read. A couple of years ago, I think it was in 2015, 16, around there, Lisa Rosenbaum, who's a cardiologist, wrote a series of papers about severe mental illness and the mortality gap. And she's really provocative, and she talks to people who do this work on the streets, so street medicine, folks who have developed clinics like our MIPS clinic, and she really thinks about implicit bias and all the challenges of our health system and why we're doing such a terrible job taking care of these people, and puts the onus on us. And part of it is just that it's really easy to just say, it's too hard to talk to these people, they're scary, I don't want to deal with it. They say they don't want care anyway, so let's just leave them alone. And that's just a huge mistake, because once again, preferences may be implicit, and we need to be able to better understand what people really want. So I started thinking about, well, what is it that we really need to do to improve care? I think that our med psych model makes sense, but what is it that we're doing? And of course, there's stuff that happens before the patients get into the hospital that's really important. That's the MIPS unit. So thinking about preventive care, lifestyle changes, all the same things that we think about for anybody who's in primary care, all the things that help all of us, help patients with severe mental illness as well. But we really want to be thinking about what is it that we could tailor and do differently. And it occurred to me the thing that's most important is having a high functioning team. And that's something that I feel really proud of. I see a couple of our team members out in the audience that we really have worked over the years to make sure that we are listening to each other and recognizing what expertise each person brings, because that's so needed when patients have a multitude of issues. And this is just an example from our website of the way that we think about our daily interdisciplinary rounds, for example. Each team member has a task, and this flows very seamlessly now, but there was a time where we really had to work on this. And then I was thinking about this piece of tailored and targeted care again. Patients really want this one-stop shopping. They're coming to MIPS. Increasingly, they want their psychiatric care cared for there too. Well, so next door is strong ties. How do we, continue to move and improve that? And then what do the clinicians bring that really bring this, this better care to the patients? So this led me to sort of say, okay, I want to know what it is. How do I study med-psych units? How do I create a career out of this? I think what I need is a sabbatical, and and sort of had to talk to my chair about that and say, I need to figure out how to do this work. This is so different than what I've been doing. And it turns out that the people who do this work the best happen to be in the country that my family's from, which is the Netherlands. So why don't I get to go there? So I wrote a whole thing, and I met this guy who was doing his PhD dissertation at the time on med-psych units. The Netherlands has the most med-psych units out of any country because it's now been mandated in all of their academic institutions, and that's basically because of cost-effectiveness analyses. They've been able to show that you can reduce costs if people get one-stop shopping while they're in the hospital. And what they do is they have co-rounding with a psychiatrist and an internist on each patient, and they address the needs of the patient while they're in the acute setting, and they get them discharged sooner, and they have better outcomes. And this just gives you a sense of where the med-psych units are. Martin van Schijndel has done a lot of work thinking about mostly sort of cost effectiveness, how you make this argument, a lot of health policy work in the Netherlands. So he's just been great to learn from. And when I went on the sabbatical, I got to meet other folks from Japan, as well as the US, including Roger Cathal, who is sort of the grandfather of med-psych units here in the United States. And we talked a lot about what are the priorities here, what do we need to learn, and there's a lot. Basically, no one's really been studying it very well. And this is where we kind of started. What do we really know so far about MPUs, med-psych units? We know they develop spontaneously, in different places and simultaneously, but in isolation. So one would pop up here, one would pop up there, and maybe they would communicate if they knew each other or somebody knew that there was another one, but there was no systematic idea of what it is you need for a med-psych unit. And usually they start because of some kind of challenge, usually an unfortunate patient outcome. Perhaps a patient had a suicide attempt while they were on a medical unit, and the hospital goes, whoa, we got to think about a different way of caring for these patients. Or alternatively, a bad medical outcome on a psychiatric unit, right? Oh, we really need to figure out how to do this differently. Let's start thinking. But it's not really clear how similar and different all these units are because not everybody's writing about it. And it's really hard to find the people who work on these units and ask them these questions because everybody's busy and it's overwhelming. And most of the literature that's out there has been one unit at a time. Just to give you an example, for those of you not familiar with med-psych units or our med-psych unit or what we do, generally we're taking care of patients who have concomitant medical reasons. They have to have an acute, usually an acute reason to come in medically, and then an underlying psychiatric illness. So for example, someone with Parkinson's and depression, where the depression is really impacting their care and whatever they're presenting with in terms of the Parkinson's. Or another really good example is somebody who comes in after an intentional overdose, has suicidal ideation, right? And they need some psychiatric support, maybe some monitoring with a one-to-one or nursing care that understands how to kind of keep an eye on those things, as well as monitoring the medical issues. These are just some examples. So we started looking into what do we already know? And this is mostly my colleague Martin van Schijndel's work as part of his dissertation. He's actually was a Dutch guy who figured out what's going on in the United States. And so I started partnering with him after this work. And actually some of the residents here were a part of this initial study where they cold called hospitals throughout the country and just got somebody on the line and said, hey, do you guys have a psych unit? Do you guys have a psych CL team? Do you have a medicine unit? Do you have any place where they do both? And if so, can I talk to the nurse manager? And it's a lot of like people hanging up on you and a lot of repeated phone calls until finally you get a hold of somebody. So this data is dirty, if you will. It's really hard to come up with a definition of what psychiatric care is, what medical care is that people agree on. But the Dutch group kind of created basically a criteria that they considered to be concomitant medical and psych care in one place. And it couldn't just be a consulting team. It actually had to be that they were delivering some sort of IV fluids plus, psychiatric care for psychosis. And what they found was, out of all of this cold calling, and they actually didn't make it through all of the hospitals in the country, because that would have been very daunting, but they got through half, about 50% of all hospitals that are known in the United States. And what they found was that less than 2% met the criteria. And their criteria are fairly broad, like they aren't the criteria that I would now use for a med psych unit, but less than 2% of hospitals have a place where you can deliver concomitant medical and psychiatric care. Further research on a smaller subset of these units have learned that probably about more than half of them are in academic hospitals, which kind of makes sense because that's where a lot of innovation is sometimes easier to happen. While more of them are locked units, a lot of them are not locked units. Some of them have capability of being locked. You can see the range of the size of the number of beds, IV access, just to give you a sense of what we're talking about. It was interesting to see that most of the administrative responsibility does seem to fall on psychiatry departments. There are a few that do both joint medicine and psychiatry. So for example, our unit is the administration, it's through their psychiatry, but it is a medical unit. And then it's interesting to see resident participation, because there's a huge opportunity, right, for residents to learn from these units. And as you can imagine, it's usually psychiatry residents if it's in a psychiatry department. Medicine might be more likely in others. And then this is interesting. So psychiatry and medicine residents, those are people who are doing a combined residency program in medicine and psychiatry. And most of the med psych units are in fact in hospitals where those residency programs exist. Makes sense, right? Great place for them to work, and they can continue to work in them after graduation and really utilize both skills. But there are not many of those programs in the country. Okay, and then you can see that med students are really getting a lot of exposure to these. So this led to what you heard earlier, that I, with the backing of Dr. Lee, was able to start an Association of Medicine and Psychiatry. And we started meeting through the Association of Medicine and Psychiatry, which is, we started the Medicine Psychiatry Unit Consortium, which was through the Association of Medicine and Psychiatry, which is the conference for people who are dual boarded in medicine and psychiatry. So it made sense, again, to find the people who are doing this work and who are interested in doing this work and really collaborating across these units, and perhaps also developing more of them. And one of the first papers that led to my co-leaders in this group was written by Aubrey Chan, who was at the time a resident at the University of Iowa. And he just did a very simple comparative, the first paper that really compared a series of different med psych units. And again, today we might not all call them all med psych units, but they're different models of delivering integrated care. And that allowed us to start creating these relationships and talking at national meetings and getting a listserv and finding other people who are doing this work and trying to create some consensus. I think some of these slides we don't really have to spend a lot of time on, but just so you kind of know why hospitals might start these units. And here's some of the preliminary work that we did with the consortium. So the University of Iowa is the oldest med psych unit that we know of in the States. Again, a place where there's a combined residency program. So they've been around since the 80s. Our unit started in 2007 with 10 beds and quickly went up to 20 beds, actually the year that I arrived here. And as many of you know, we now have a second unit, G92, so we have an additional 10 beds. And another partner who's been really involved in our leadership is from the University of Cleveland, Case Western. And she was just opening her unit at the time with a slightly different model. And so we thought, great, we have 3 people who are running these units. Let's try to gather some data and just start with presenting this and kind of getting some feedback on what are the things that we do differently and how does that impact what happens to the patients and who are the patients we see. So you can see there's a range of different ways of doing this, where it's located, the type of unit, who it's managed by. Also slightly different kind of teams. So the Cleveland model is actually a little unique in that they have a space in the hospital that primary teams can move through. They can bring their patient there, stabilize them, and then take them back. So for example, a patient develops delirium and really needs that medical and psychiatric care or oversight. They could transfer them from a surgery unit to the med psych unit. Once they stabilize and get kind of treatment planned, they go back to surgery and then go discharge from there. Okay. And then what we were able to do was start to develop a little bit of data gathering processes, which is not as easy as you might think. So we have these wonderful electronic medical records and great ways of getting data, but how do you know you're collecting the same data across different settings? And so there is this thing called Vizient, which is a database which supposedly tries to normalize what we call things and how we bill for things. And so after a lot of work working with this database, a database that our hospital uses to track outcomes, and getting data agreements with other universities, we were able to do some basic comparisons about patients just in 1 year. And you can just see some differences here. A lot of the differences we see may have to do with how the units were set up, who cares for the patients, where they're located. So for example, University of Iowa, you'll notice right away, there's only 7% of the patients are Black, whereas University of Rochester and Cleveland have a much higher percentage. So just kind of giving you a sense of differences there. And then the next step was to see if we could demonstrate the feasibility of actually really trying to embed some research in clinical units. And I know that this is something that's very dear to Dr. Silverstein's heart, to how do we kind of utilize these really innovative services that we have at places like University of Rochester to actually do research. This was pre-COVID, I will remind everybody. So it was a little bit easier to get nurses on board with trying some things that are not necessarily part of the clinical day-to-day. And it's much more challenging now with all the competing demands that nurses have and the low staff. But it is doable. And so it's a matter of continuing to engage with them, getting them on board, and using our quality improvement processes. So the next chapter was really, okay, so now I've got a sense of what this is and what I want to do, and how do I really create infrastructure so that we can do this research in a more systematic, careful way. And so this this was a low period in my little travel, my little route. It was a big turn to the side. I've been trying to get funded to do this work, and I thought we wrote this great grant to the National Institute on Aging to really say, hey, this population of patients with severe mental illness who are cared for on these units, we have this consortium, we have this preliminary data to show that we can collect data, and we really want to think about a pressing issue, which is that they're aging at an earlier rate, they're dying earlier, and it's a challenge for them to stay in the community, and it's overwhelming, and it's going to keep overwhelming at an exponential rate our health system. So how do we use this prescient issue to really get some funding to do this work? So it was scored, and actually we got a lot of good feedback, and we resubmitted it, and then it got a lot of good feedback, and it still wasn't funded, unfortunately. And that may have partially to do with the largeness of the study and the number of things we wanted to do, and probably also sort of funding priorities. So the National Institute on Aging, as you might imagine, has more priority of focusing on Alzheimer's than they do on severe mental illness. So we shifted gears a little bit, and I kind of got together with Steve Silverstein, who had arrived at our department a couple years after I started doing this work, and started thinking about this accelerated aging aspect of schizophrenia, severe mental illness, and really, again, this complexity and how med psych units are a place to study these patients. It's a captured moment when they're on med psych units, but also in our med psych outpatient setting. And Steve's work around retinal markers was really intriguing and exciting to think about what is the physiology versus what is the kind of the social determinants of health that affect aging and have an impact on these patients' lives. So we submitted that. It was unfortunately unscored the first time, but we're gonna keep working on that and come back around to that. So you might hear about that in another future lecture. So here's that road again, and I just want to remind you, it's been a challenge. I've also submitted a lot of foundational grants for little projects here and there, so I'm not giving up, and the road is still very beautiful, and those mountains are still in the background. And what I'm doing in the meantime is writing papers and really just collaborating with my other med psych units, kind of trying to think about things like consensus and how do we decide what a med psych unit actually is. We've actually published a couple of papers about our own unit. This was an exciting one showing our model of care, and we were able to show that we do have a reduced length of stay and a higher likelihood of discharge to home when we compare similar patients to the patients that are admitted to our unit versus all other medical units just in this hospital. So there are things that we were doing right on that end. So that's encouraging work. We also wrote about what we really think is the important value of med psych units to care for this population, so the severe mentally ill. Med psych units will care for a lot of other types of patients who they may or may not be well equipped to handle, but have both medicine and psychiatry. So we wanted to really establish ourselves as saying there's a need for this population, and we want to show that. And this was some of the model that we've been thinking about in some other papers, that we're really, this team-based approach and integrated medical and psychiatric care is what has an impact on outcomes. And so this is kind of where we're at right now with the consortium, thinking about consensus. And so we did what's called a Delphi consensus project to get input from all of the experts, people who work on med psych units or have med psych units in their hospitals, asking them what they think are the most important parts. And I thought this slide was just, so this is in progress, but just to kind of give you a sense, one of the things that is very necessary is that you have a dedicated unit. Most people agreed on that. What they thought was less important was who was administrating it. So it doesn't matter if it's medicine or psychiatry, it just matters that there is a dedicated unit. Some other really important things that came out of the consensus work is that there have to be really clear plans of who the target is, what the patient population is, and how you triage and have admission criteria. Otherwise, unfortunately, it becomes a catch-all for anybody who is challenging in the health system. And we see that all the time, and we have to push back, and it is one of the hardest pieces of our work, is letting people know that this patient is not, just because they're difficult right now does not mean that they have a psychiatric illness. Other really important consensus findings were that the cohesion of the team was as important as the expertise. So while it was really important that you had a psychiatrist or a mental health specialist and a social worker, it was as much about how the team interacts and listens to each other and supports each other's expertise than it was just about who's there, which of course makes sense. And I bring this up, I see Zipporah sitting at the back, who's I know a big team advocate, and there's a huge opportunity here for anybody who's interested in team science, because there's so much to study on our unit from that perspective. Okay. And then the other piece that was really important was quality monitoring and outcomes. And in fact, we had a section in our survey where people could kind of write in other suggestions beyond just the survey data and consensus questions. And the sorts of things that came out in the qualitative recommendations in those little sides of the survey were things like build in metrics from day one. So again, like as people are opening new units, there's new services happening in psychiatry, think about this. How do we build in metrics that we can study from the start? Bring a researcher on board so that you're not trying to retrofit it, because there's so much data to be gathered, and we're doing innovative work in this department, and we really need to figure out how to disseminate it. Okay, so that's kind of where that leads me to now. And the brand, this idea again of coming full circle, and this was actually a conversation I had with Dr. Lee, who was like, you know, what about all that stuff you did before, and what do patients actually think about med psych units? And so some of the quality improvement work that we've been doing has been focusing on how we can reduce readmissions and communicating with our outpatient practice, the MIPS primary care practice. And so this is just to show you the kind of data that we collect all along, and the hospital helps us with this. These are comparing our med psych units, our patients from the MIPS clinic, when they get admitted to the hospital and they come to our unit versus they go to a medical unit. What happens in terms of readmission? And we are the blue little columns, and the orange columns are all other medical units. And what you can see is that we have lower readmission rates. We don't have zero readmission rate, but we have a lower readmission rate. So that's encouraging that we're doing the right thing and we're connecting well, but there's area for improvement. So this is one of our quality improvement projects, and there have been a lot of pieces to this. But it occurred to me, going back to that idea of what patients want, what if we sort of incorporated patient priorities and actually involved them in the process? Maybe they could tell us something differently about why they're getting readmitted, and maybe we can even prevent them in the first place. And so together with some colleagues, Lorraine Shield and Elaine Rigney, we put together a small internal grant to the URMFG Quality Institute, and said that we would look at, could we develop some ways of accessing patient or assessing patient priorities on the unit while they're there prior to discharge, and incorporate that into the programming that we were already working on. And this is our very fancy name, VIP SMI, so vertical integration for patients with SMI. Vertical integration is just the idea, as opposed to horizontal integration, which is like collaborative care. We wanted to think about inpatient to outpatient care, and how do we collaborate across those settings? And how do we do a better job of closing the loop when patients are transitioning from outpatient to inpatient and inpatient to outpatient? And so this is the tool that we've started using. So going back full circle to my original work, very simplified version of it, little app tool that we can use on the unit to ask patients what's important to them. This has evolved, this is an earlier iteration of it, but kind of we want to know what's most important to you as you prepare for discharge. What are the things that you're worried about, or what are the things we haven't addressed while you've been here? And because it's a low literacy group, we use a lot of pictures, pictorials, and then we allow them to kind of tailor and say what these things mean to them. And these are based on feedback that we got from patients and from physicians in the primary care setting, as well as on the unit. What are the things that they might think are important? Things like managing my medications, feeling safe, doing things on my own, right? And it's a kind of iPad app, so they can just use their finger to move the picture into each section of what's most important, least important, somewhat important. And then they get a little printout thing that we're still now working on how to incorporate that. But the idea might be that it would eventually go right into the Epic. I have a little section right next to the sidebar summary or the problem list for patient priorities. It would live in the chart. It could be updated, and it could be something that the primary care physician sees. It says something that the nurse could say, hey, I see that the priority for you is managing your medications. How's that going? Would you like me to talk through things? Right, and so that would be just a way of really engaging the patient more. I just want to give you some preliminary data. This is a small subset of about 40 patients. We found it interesting to look at a group level as well as on the individual level. This is at the group level, a very busy slide, but what you see here is that what seems to be most important to most people is managing my medications. And as we drill into that a little bit more, we think that that is actually their psychiatric medications, and that some of them don't want to be on their psychiatric medications. So this is knowledge and important to understand, because there's an opportunity. Perhaps we're not spending as much time talking about that with them on the unit because we're focused on their medical issues or the integration piece. So there's some things to work on there. And the other bars tell you what are the second most important or the least important. And I think it's kind of interesting that the most likely to be least important was something else, so whatever that is. And then the one after that is, I think, improving vision and hearing. I did think that it was interesting that feeling safe was not super important. Doing things on my own that was the second most important. So that is kind of, helpful things to understand, and then to, really unpack what that means to patients. So the next step, even before I came here, I'm writing a letter of intent back to the Patient-Centered Outcomes Research Institute, and also thinking about other funding agencies that are interested in really doing this kind of collaborative work, starting with the community, going back to where patients are coming from, and not coming from this top-down approach of like, wow, we have all these great things and they integrate it, it's everything that we want and it's better for health outcomes and cost. To really start with, what do patients want? What do communities want? What do their families need? Do they even know what integrated care is? Does it make sense to them? And so just starting some collaboration and reaching out to folks like Oars for FAMI, which is a group that started with Steve Silverstein many years ago, family members of folks with severe mental illness. And they did not know about our units when I reached out to them. So there's a lot of work to be done there. This is just our busy division slide, and I have a little circle around the piece that I think we need to do more work on, and I think Dr. Olivares is very much behind that too. So this is sort of the next steps, I think, as we continue other research efforts. And I will leave you with my grand vision, which is to someday, if we can really build in this infrastructure, whether it's through a large grant or through small community engagement and little projects here and there, to have this center that is really focused on the integration of medicine psychiatry that allows for folks who are interested in research on teams or who are interested in research on nursing education and retention or clinical workforce development for the future of our aging population, to come to our center and say, I want to do something and study a piece of that because you've got this great infrastructure that exists already. So that is the next step in the next 10 years. Thank you. Oh, slide. Oh, yeah.
All right, well, we have just about 1 minute left, and we do have a question on the, in the 1 minute we have left, we have a question on the, on Zoom, and this is, thank you. First of all, this was an excellent presentation, and this Kim Van Orden thinks you should give a TED Talk. And I agree, it was an excellent presentation. The question is, could you say something about whether you think dimensions of social connection play a role in the mortality disparities? And if so, do you think that could be addressed on the unit?
Absolutely, come work with us, Kim. Yes, of course. I think human connectedness is so critical. And for many of our patients, especially as they're aging and they have functional decline, they are homebound, or they're living in group homes, psychiatric group homes, where they have some access to some services, but maybe not as many things that they can do as they have physical barriers, and the group homes, psychiatric group homes can't manage the physical issues. So there's absolutely a huge opportunity there. And it is something that we've talked about a little bit, like how we could assess that on the unit. And I think our nurses would be really interested in talking about more about that too.
Okay, does anyone have any other questions, especially that could be spoken and answered in less than 30 seconds? Well, I guess everything was made clear. I just want to say, I agree, like I said before, it was an excellent presentation. I think it really helps to see where you came from and all the experiences you had and how you developed the ideas over time. That was this very unique aspect of this that I hope we can have more of with other presenters.
Thank you.
All right, everybody, have a good day. Thanks for coming.